All right, good morning, everyone. Thanks for having me. Certainly, I'm very excited to talk about that topic. And it comes with my disclosures that I have none, but that I have dedicated my professional life and career to find out about the phylum Terminale and its pathology and what can go wrong with it. Remind you, I'm glad that Dr. Levy talked about the embryology, but I want to just add that the phylum Terminale that causes tethering was once embryonic spinal cord when we were still having our little tail as an embryo, and then something in week 10 or 12 goes wrong with that tail and can cause a lot of trouble. So I always talk about our little tail that we still have in our spinal canal that was once embryonic spinal cord. And I'm saying this here because later on in my talk, I'll talk a little bit about our histology findings in tethered cord that might help us understand what the problem is, which might not just be blood flow and blood circulation in the spinal cord. So I'm going to give some highlights about the clinical diagnosis and what we find out about the diagnostic criteria of tethered cord to educate you the so-called triad of symptoms, and then some nuances about neurosurgical management of tethered cord complications and technique improvement. As I said, the pathology, and then some of the research that we're doing at Lifespan and at Brown. So when you go to the pediatric textbooks, that is how the tethered cord syndrome is described. Of course, for most, we're talking about unexplained urinary symptoms in the pediatric and also in the adult population. And it's frequency, urgency, retention. In kids, you don't want to see more than 3 UTIs a year. And certainly, we also have bowel problems along with the bladder symptoms. Bowel problems in isolation without bladder symptoms make you shy away a little bit. I have a few experiences of kids with just bowel constipation, but the results are pretty much like 50-50 in this population if they don't show in conjunction with bladder symptoms. And then you have the neurogenic pain symptoms, which go in the legs. They are often not really dermatome related, means like they're not always on one place. They show up in a various fashion, aches, fatigue, soreness, tightness, and then often they affect one leg one day and the next day another leg, or so they travel. And then what is very important that the neurological findings are different based on the age range. In the infants, you often observe like different leg movements or decreased leg movements, absent reflexes, and the tone is low. Whereas in the younger adults, you have more spasticity and higher tone. You could think that this speaks for a longer persistence of the disease and more tethered cord, spinal cord kind of abnormalities and pathology caused by the traction and caused by abnormal blood circulation and damage to the spinal cord, which can be related to spasticity and higher tone. But in the toddler, here is a little bit the gray zone, because we think that in a toddler we really don't want to necessarily intervene surgically because that is a developmental population. But if you look hard enough, often in even in a developing toddler, you can see like some sustained symptoms of abnormal walking, toe walking, asymmetric findings of toe walking, and asymmetric tone in the legs with differences in the reflexes between the right and the left leg. So asymmetry is a very concerning finding for tethered cord, and I talk about it later. Certainly teenager pains, growing pains are often overlooked. And leg weakness shows up later on as there's probably more progression with the disease. And then the orthopedic findings, Dr. Levy talked about the deformities, and so I don't have to talk a lot about that, though I don't do spinal deformities, so I think his talk speaks to the fact that tethered cord does in fact cause not only spinal deformities, but also other skeletal deformities. And there you can talk about like how the joint pain that we sometimes see in patients with associated connective tissue disorders comes into play, and then joint weakness, or I call it functional deformity. Sometimes people feel that they have pain in their joints the more they walk, and with longer distance of walking, feet turn in, or you ask them, do you feel that your leg is more painful, weaker? Does your feet feel funny? And that's often confirmed by the patients. And of course, you look for dimples. That's picture. So we really want to find out what is diagnostic for tethered cord. What really is the symptom that makes us to be comfortable that we are dealing with symptoms associated with tethered cord. So, and also what might be the symptoms that are most predictive of surgical success. So that's why we went on and we scrutinized our data in patients with occult tethered cord syndrome, because this is really the population where we go off the symptoms. These are patients that don't show the classical criteria of tethered cord, and I talked about that earlier, like the low-lying QonoS, below L2 level, and often like a phylum that you can see in the MRI that has some abnormal signals, often fat. Now, these are the patients that have no evidence in the MRI of tethered cord. The QonoS is at the appropriate level, and also you cannot even see the phylum. And in those patients, you go off the clinical symptoms. And we all understand that this is very controversial, but it does exist. And here is the literature where one of the pioneers, Monica Levy, had described her first series of 60 patients with radiographic negative evidence of tethered cord, and where she treated them based on abnormal urodynamics that weren't explained otherwise, and with good results. There were others that followed her. I just want to mention that this is backed up by pioneering work by others. So we scrutinized our data, meanwhile there are more, but back then, a year ago, we had more than 100 patients that had symptoms in the realm of the triad, like urological findings, skeletal findings, as well as neurological findings. And then we looked at the surgical outcomes, the symptoms, as well as the pathology of the phylum, to see whether there's anything that we can learn from those patients where the tethered cord doesn't show classically. So a busy slide, but let me just, we did a univariate analysis of like outcomes. Within the first 3 months, you see 0 to 120 days, and then post 3 months to a year, and then also looked at the prevalence of the symptoms. Of course, you can see that urinary incontinence is number one, 68 out of 112 patients. But we all have, they're all like these symptoms that are described. And interesting is that the constipation and the bowel incontinence, is not really like a sign, even though you see it often, but the improvement is not as great. Then in the neurological score, you see that leg pains, weakness, as well as fatigue and soreness and cramps often are described. And in younger adults even, you see that they complain about falling and tripping, which certainly is a concern. And then going on to neurological findings, lower leg hyperreflexia versus lower reflexes in the upper extremities is often seen in those patients along with the QonoS. And weaknesses, of course, you see, as I said, often asymmetric. And then the orthopedic findings, I put the pain in there. That might not be very smart, but certainly back pain and also lower leg pain is important. And then often people describe like something is pulling on their spine. They feel like the head is heavy, and they feel often pain and abnormal, discomforting symptoms running up and down the spine, which I hear very often, so this is real. Anyways, this should show you that this is how we analyze the data. If there is this decision here, we might do it differently, but that's what we came up with, that the most frequent findings in the urological realm is leaking and incontinence, together with constipation, constipation not in isolation, and the urinary retention, back pain, foot and ankle deformities, often functional when people walk longer and when they get tired and exhaust themselves, and as I said, often asymmetric. and the scoliosis. That's certainly very blunt here compared to what Dr. Levy talked about. The neurological symptoms, lower extremity pain, often number one. Number two, lower extremity weakness and decreased sensation that you also that people are describing, that when they walk a long time, their legs go numb, and then, as I said, scrutinize the patient for asymmetry in the neurological deficits, like some minor weakness in one leg. And often that is also the leg that shows more pain. So I also always ask my patient, tell me what leg bothers you more. And if there is a clear understanding of asymmetry and differences in the sides, that is a good indicator. Hyperreflexia, foot QonoS. So we kind of identified the top three symptoms in the uro, ortho, and neuro realm, which also have the highest diagnostic accuracy in terms of identifying tethered cord syndrome, and also show the highest likelihood of improvement post-surgical intervention. So the kind of algorithm that we came up with is that now when we approach patient, and here I'm mainly talking about those that have not the classical radiographic criteria, if they have like 3 out of symptoms in all in the entire triad, like 3 out of 3 with bladder, bowel signs, and symptoms supported by urodynamic abnormalities. Then we go on, and if there's progression of symptoms, we go on and offer surgery. If they have only 2 out of the 3 symptoms in the triad, we try to see whether there is some radiographic evidence of tethered cord, maybe a borderline, low-lying QonoS, and I talk about that in my next slides, or a fat signal. So minute findings of progressive Syringomyelia, spinal bifida occulta on X-ray. Sometimes you see on the X-ray that the lamina has not fused, along with a neurocutaneous sign, a dimple that might be suggestive and puts us at a higher evidence of that a patient or a person might suffer from tethered cord. So certainly we include comorbidities. Syndromes are often like the classical, the Vader or the Vectal syndrome is associated with findings of tethered cord, and other syndromes that are now more understood in the genetic field that show an abnormal phylum. Anyways, if you are not certain, monitor, go on and monitor your patient. Don't send the patient away. And then often if there is tethered cord, symptoms progress within 6 months or a year, and it's not the first time that I see a patient coming back with more obvious symptoms, and then you have more certainty and more accuracy. I want to say something about the urodynamic findings. Certainly classically, and that's also described in tethered cord, particularly in patients with spinal bifida, that you want to have the detrusor sphincter, the synergy. However, in our patient population, I have to be honest here, this is adult and kids, certainly might be a bias here, but our urologist looked at our data and found also that there's a high prevalence of detrusor underreactivity in those patients that responded well to tethered cord intervention. And so it might not just be the detrusor sphincter dyssynergy. So now I kind of embrace, if we do like very extensive and exhaustive urodynamic studies, to embrace like any detrusor abnormalities that is not explained otherwise and that does not respond to conservative management and treatment, embrace it and look at it. It might also be associated with tethered cord. So I want to advocate here that we should not dismiss a person by not quite the classical findings in the urodynamic study. I think we still have to understand how the urodynamic study applies to the tethered cord syndrome in the classical and also the occult tethered cord patients. But anyways, we presented that on a conference on the Urological Functional Society, and trying to also help urologists to understand. I want to say something about the radiology. So we looked at the patient that had great outcome a year post-surgery, and we looked at their QonoS levels and some signal in the phylum maybe, and compared that to controls. Our age-matched controls were patients with back pain. You might argue, well, how do you know that they don't have tethered cord, but they had a problem with discs and had more obvious problem that the back pain was related to other degenerative findings and not a neurological issue. So we looked at the QonoS level in those patients. These were 28 patients, and 2 radiologists independently looked at those. And what we found is this. Certainly, there is not a significant difference between the controls and the tethered cord patients. But I want to say here that there is a little bit about a battle that I'm fighting with my radiologist about the L2 QonoS level. Because often, and you know, radiologists say, you know, no evidence of tethered cord QonoS at the appropriate level at L2. But if you look at the patients with the tethered cord, they have, you know, like they kind of, you know, cruise around the L2 level also, and not just the or L1, L2 level. So there is a preponderance of a QonoS being at the L2 level, and maybe it's important to describe whether it's lower L2, mid L2, or upper L2, and maybe lower L2 level is already good enough to establish a borderline criteria, particularly if we are looking at the tethered cord syndrome. So I had asked my radiologist to please not write down evidence of tethered cord, but instead to describe what the QonoS level is, and simply to get away of that, you know, stigma of that the MRI has to show the QonoS at the appropriate level. We don't even know what the appropriate level is. Anyway, so we presented that at the ASNR, and we, you know, we had a good discussion about the QonoS level and made neuroradiologists thinking differently about it. And then also, you could argue, this is a slide where we re-imaged a young kid where you couldn't see the fat in the phylum, but then in the second image in the MRI, you see a little dot there in the left slide, where the cecal sac is. So sometimes you could argue the fat is escaping the imaging because the phylum is moving with the CSF pulsations, so you might just not see it. So we might need better imaging as well in order to correct for that. Let me talk a little bit about the surgical management. Certainly, and here I'm certainly anxious to hear what my neurosurgical colleagues say. Does it really matter where we resect the phylum? Pediatric neurosurgeon, and Dr. Levy might correct me if I'm totally wrong here, maybe think of getting the phylum a little higher in order to avoid retethering. If we classically think of a fatty phylum, as in that MRI, it goes all the way from L1 to the sacrum. Certainly, we can discuss where to approach it, because it's known that the fat can reattach to the dura. So should we get it in a higher level in order to eliminate the reattachment of the phylum still being attached to the cord? Anyways, that is a discussion. I'd like to not propose anything here. In my practice, I go below the QonoS and a L1-2 or L2-3 laminotomy to resect a piece of the phylum. And I have reoperated some patients that had a low approach to the phylum. You can see here the phylum on the nerve hook. And this should show that the phylum, in fact, even the non-fatty phylum can get reattached. Apparently, the structure of the phylum is just sticky and can get reattached. So again, that also advocates for not dismissing reoxygenation of the phylum if there's recurrent tethered cord symptoms. Certainly, this has to be scrutinized very thoroughly. Just an example, that is a kid that had a low tethered cord intervention for a fatty phylum. You can see the phylum is still there, and it appears that it's reattached down there at the level of L4. And the reoperation shows that you, in fact, can safely go higher. And there's a little white dot on the tip of the QonoS, which is the rest of the phylum that was resected for recurrent tethered cord symptoms. So again, it's certainly not an easy discussion, but it matters, in my understanding, that where you approach the phylum, and maybe you do it at the first place. Certainly, the concern here is with any of these interventions, the complications. And the two complications that one should try to avoid, by all means, with whatever technique is best, is the arachnoiditis and the pseudomeningocele, because these can affect the outcome. The arachnoiditis can cause lifelong pain, and tethering that is not surgical correctable anymore. And what is that? That's just inflammation that can occur with any intervention that we do in the spinal fluid, that occurs with Chiari and other things. I have a picture down here where it shows that the nerves clump together from chronic inflammation and adhesion, that the inflammation just kind of glues them together, and that is associated or can be associated with pain, and that's not correctable. Other than with pain management, of course. So that should be avoided, and then also the pseudomeningocele, which is sketched down here, where the nerves can protrude to a dural opening, and then they are entrapped. That you have to go back, but you always wonder with doing nasal surgery to correct that, can you cause inflammation and problems with the nerves then? Because when you go back in, then you see that it's a picture where the cauda is actually attached to the dura. You see like a little web there. There's an arachnoid that has scarred the nerves, and this is something you don't like to see, and that certainly is always the anxiety that you have in your heart and mind as a surgeon. Certainly, in order to avoid arachnoiditis, I try to believe that you're going to have to provide a clean surgery, no blood in the thecal sac, and with cotton paddies, you can try to make the intrathecal intervention clean. And then that I kind of learned from my experience with treating people with occult tethered cord syndrome associated with connective tissue disorders. The dura is somewhat weaker. I learned my lesson. We as neurosurgeons always do the Valsalva maneuver when we close the dura. We ask the anesthesiologist to pump air in the lungs, and then, up to 40 millimeter mercury, we'll look at our closure. You can see here the proline closure, and we think it looks nice. There's no spinal fluid oozing through, but that might not be accurate for anyone. So now I tend to harvest some fat from the flank and put it over the suture line to avoid, by all means, the pseudomeningocele. That is a little bit of a technical nuance to avoid complications. Certainly, the big million-dollar question is, and I have no answer, but it came to me to patients. I know that Dr. Bolognese, he's not here, he does prone MRIs, but maybe Dr. Kula has something to say, to see whether patients are retethered, particularly those patients, that applies for any patient after tethered cord surgery, because we do supine MRIs, and then if we want to scrutinize whether someone is retethered, should we be maybe doing prone MRIs? This was actually a lady from Austria. She came with her prone MRI in my office and told me, no one wants to do surgery on me, but look at my prone MRI. You see that when this is the prone one, where you see the QonoS swings back to the posterior level of the spine, and it looks like the nerves are attached, and in the supine MRI you cannot see it. The question I have, certainly, that needs to be studied more scientifically, and to randomize patients prone versus no prone, and certainly we don't even know whether this is of clinical relevance. I wonder whether this is certainly also a post-surgical findings. That is just being a little provocative here. But yes, we have to look into it to really not dismiss any person that might be retethered for other reasons. Okay, so I'm going to talk about our pathology and histological findings, and that is the research that we're doing right now in order to understand what is it that the phylum does, or what is tethered cord. Is it, as Yamada and Dr. Levy mentioned it, is it disturbance of the spinal fluid blood flow circulation, or is there more in that phylum that causes the symptoms, particularly the asymmetric symptoms that Dr. Levy also mentioned, which might be is a tethered cord just randomly affected by some blood flow circulation, and we know that the asymmetric findings without and with the syrinx are very diagnostic, and how come? So we looked at the histology of the phylums. I told you earlier, my practice, I resect a piece of a phylum, and so we look at the pathology. There's not much like about how a normal phylum should be. I found one in Dr. Google, I think, phylum picture from a cadaver where you can see down here the wavy collagens. They are all aligned nicely, so that's supposedly a picture of how a normal phylum should look like. So when we look at our, these are both occult and non-occult phylums, but look at this upper left. You see like these white thingies, this is fat. And even in the occult, I just told you the fat can escape the imaging. You have often a decent amount of fat in the phylum that you don't often even see in the operative view. But what is also important, and that had actually been described by people that looked at the phylum decades ago. I know Dr. Nathan Selden in Oregon had looked at that, hypervascularity of the phylum. We know that the phylum has some veins and arteries, and it's supposed to also drain some blood flow from the spinal cord. But in the phylum pathology, often the veins can be very congested. In our patient example, we sometimes found a venous angioma in the phylum. So maybe the phylum congestion is also making the phylum a bad player, maybe a bad shock absorber. And there might be another element of phylum congestion, blood flow abnormalities on the venous drainage end that might make the phylum sick. Actually, particularly in people with connective tissue disorders, we sometimes see large vessels in the phylum that take up one-third of the entire phylum diameter. And then, of course, not a surprise, the embryonic junk in the phylum, the dysplastic ganglion cells, or ependymal lining, which is often seen in patients where the syrinx is associated with the tether cord, so the central canal extends into the phylum. These are also seen in the phylums. And this is another example where we see often a lot of vessels. You know, these sausages this is a Giemsa stain where you can see the vessel better. The collagen is blue, and then the vessels are more reddish, so you can see it better. And then also a lot of fat there, and this should show the ependyma. And certainly these are not regularly structured tissues, so the collagen is a little wavy, messy, and that made us think that maybe there's a collagen also a bad player in the phylum, and abnormalities in the collagen are found. And I show you some pictures later where we found out that the collagen is abnormal in the phylum terminale, and that has been described actually by one group 20 years ago. But we also find inflammatory changes, which I don't know what this is all about. I mean, you could say, well, it's an embryonic spinal cord, why shouldn't there be inflammatory cells? And also, could it be that some inflammatory cells from the spinal cord invade the phylum? This is microglia in the phylum down here. That is CD86 immunohistochemistry. We find also activated mast cells positivity. Dr. Maitland brought that to my attention. She wanted me to look at the mast cells. This is tolloidine down here, the middle lower. These blue guys are the mast cells. This is CD117 on the left lower. Positivity, these are activated mast cells that just reacted to some external stimulus. And then CD45 lymphocytes. So you have immunology in the phylum. Is the phylum also a bad structure that reflects or mirrors maybe some neuroinflammation that happens in our spinal cord? Let alone certainly like the abnormal collagen structure here. And this is the mast cell. Electron microscopically, it's in there and is heavily interwoven with the collagen. I cannot give you an answer. I just being descriptive here that, and also for the neuropathologist, that they should look at the phylum and also look at abnormalities that in the future might be helping us to understand the pathophysiology. This is collagen. So we looked at all the phylums were sent to electron microscopy in our patient population. And we started, I wasn't expecting that to be, but we started to see, this is how, in the left upper, this is how normal collagen looked like. This is a cross-section, so like black dots. And then these are all patients. In some patients, you see like that the collagen is a little bit more loose, more spacious here. And then this is still a cross-section, but now you see that the collagen is all messed up. You see like interwoven, like short structures, and then the yellow arrow is pointing to like a corkscrew-shaped collagen. And then down here you see that collagen almost disintegrates. And also a lot of like abnormally woven collagen. And then I want to point to one article I found. I thought I certainly discussed whether this is an artifact, but the pathologist told me they usually look in areas of the phylum where no cauterization artifact has occurred in the middle, and certainly you pull a little bit on the phylum. If that was the problem and that causes the collagen abnormality, then we would know, because not everyone has this collagen abnormality. So the phylum is not always abnormal. The collagen is not always abnormal. You sometimes see normal collagen, so it can't just be a artifact. Otherwise, you would have it in every phylum. So Fontes is a neuropathologist, I think 15 years ago. He described it actually in neurosurgery. He looked at cadavers, and he found that in some cadavers, the phylum had abnormally woven collagen, and he already argued and wondered whether that could be actually the problem of the phylum. You have abnormal collagen and a bad player here, and he suggested that maybe the abnormal structure of the phylum is, in fact, collagen abnormality. That's why the phylum acts differently, and that's why we can explain that some people have tethered cord and you don't see it because it's occult. This is certainly not seen in the MRI. So talking about the collagen, as we have a lot of people with connective tissue disorders, we kind of looked at whether there are differences in the collagen EM abnormality between the patients with and without connective tissue disorders. And you can see it's not statistically different, which kind of makes the point that this is more like a phylum problem, the collagen abnormality, the corkscrewing and the cauliflower disintegration. But there's a little bit of a higher prevalence of abnormal collagen. That is the green part of the pie in the EDS population, but it's nothing that is indicative of a specific problem of the phylum tied to the connective tissue disorder, but we're still looking into it. But the mast cells might be. And also the final thing, before I go to my last a couple of slides, is that what is interesting, and that's also been described, we also see often neuronal elements like the so-called nerve twigs in the phylum. These are unmyelinated nerve fibers. And we always assume that these are dead nerve fibers, and neuropathologists don't know what they should make of it. But it occurs that these peripheral unmyelinated nerves might still have kind of a function, and there are descriptions of the phylum that show that we have two types of nerves that go along the peel margin of the phylum and nerves that go into the phylum, and that's been nice descriptions. And maybe there is also like a abnormal neuronal circuit that triggers the pain and causes the symptoms. Again, just this picture is very intriguing. An unmyelinated nerve that is causing pain, neuropathic pain, woven into the collagen. So everything is connected, and maybe that's why also neuronal elements in the phylum might be bad players and affect the entire spinal integrity. That just should show that that is the integrity of the spine. The cord, the dentate ligaments, the dura, the nerves coming out, and the bony elements of the spine, they all have to work in harmony, and the phylum has to be a good player in here. So last picture, we're doing translational research. A lot of species suffer from tethered cord. In dogs, it's been described, but we had also looked at horses that suffer from a connective tissue disorder to see whether there are any similarities in the phylum pathology. I had worked together with the veterinarian medicine at Michigan, and Abby McElroy is now my research postdoc associate. And in fact, this is the horse phylum. And that reminds you, hopefully, pretty much of the phylum collagen that we found in the patients. This is up here is a horse. This is a horse in the yellow picture here that does not suffer from connective tissue disorder. You see the normal collagen, and this is a horse where you have connective tissue disorder, or a horse with connective tissue disorder, and you see the hook-shaped collagen fibrils and abnormally shaped collagen. Totally different than compared to what we see in a horse without the connective tissue disorders. That brings a little bit the connective tissue disorder and a cold tethered cord scenario in the play, and helps us understand. We're just analyzing more of the other species data to connect the dots. This is an artist that painted the Ebola virus, and I think this looks almost like the conundrum we have with the phylum Terminale, and hopefully in the future we can be more thorough and better with approaching this diagnostic conundrum. And I thank you for your attention, and certainly we have a panel, I guess. Thank you.